Good afternoon, everyone. Just giving a moment while everyone kind of files into our space here. It's my pleasure to welcome you all to our Palliative Care ECHO Lunch and Learn series for the fall. And our session today is Journeying Towards End of Life, the Meaning of Food and Fluids with Marlene Benvenuto. I'm Stephanie Hendrickson, and I'm the coordinator for the Northwest Regional Palliative Care Program, St. Joseph's Care Group ECHO Hub site, which is part of the larger national project led by Pallium Canada. So I myself work as a knowledge broker at the Centre for Education and Research on Aging and Health, or CERA, at Lakehead University, and I'll be the moderator for today. So just a bit about the ECHO project. It is a 5-year national initiative aimed at cultivating communities of practice to establish ongoing professional development among healthcare providers who care for people who could benefit from a palliative approach to care. And if you do visit Pallium Canada's ECHO website, you will find tons of education sessions there on various topics, and they are all free of charge. So while we are joining together virtually today, as the host of this session, Lakehead University respectfully acknowledges that its campuses are located on the traditional lands of Indigenous people. Lakehead Thunder Bay is located on the traditional lands of the Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. And Lakehead University acknowledges the history that many nations hold in the areas around our campuses, and is committed to a relationship with First Nations, Métis, and Inuit based on the principles of mutual trust, respect, reciprocity, and collaboration in the spirit of reconciliation. And for myself, I have come to really view this process as a process of learning, unlearning, and relearning. Like many non-Indigenous people in my age bracket, I think, I had a strictly colonial education until I went to university and learned the true history of the country that we now call Canada. I was really quite upset when I realized that none of the real history related to Indigenous people were shared in elementary or high school. So it's been really important for me that my son knows the truth from the beginning. And thankfully, things do seem to be getting better in schools nowadays, such with the educational activities associated with National Truth and Reconciliation Day, which is coming up next week. So I would encourage everyone to take part in some of those activities. As we do get underway here, we would love if anyone could, or if you all, sorry, could introduce yourselves to us in the chat box and let us know where you're joining us from. So we are very grateful to have Marlene here, and I will introduce her in a moment. Just a few housekeeping reminders before we get started. Everyone's microphone is muted. However, you're welcome to use the chat function to ask questions and add comments. You can also raise your hand and we can unmute you. And Marlene will check in for questions at certain points in her presentation, and we do also hope to have time at the end. We'll ask that you do a session evaluation for us before we leave today. And as you've noticed, the session is being recorded and will be emailed to everyone within the next week. So all that being said, it's my pleasure to introduce our speaker for today. And Marlene Benvenuto is an RN with a nursing specialty certification in hospice palliative care. Marlene has many years of experience here in Thunder Bay. She has worked in long-term care, in hospice care at St. Joseph's Hospital Hospice Unit, and with the Northwest Regional Palliative Care Program. And Marlene is currently a palliative care educator with Ontario Health at Home, and she's also a palliative care education facilitator here at CERA and a certified LEAP facilitator. So I will let you take it away from here, Marlene.
Thank you so very much, Steph. So our topic today, as Stephanie has indicated, is Journeying Towards End of Life, Meaning of Food and Fluids. It's a topic that seems to pop up quite regularly, so we thought we would do a quick overview of the meaning of foods and fluids, okay? So the learning objectives in this presentation, we'll go over some signs and symptoms of approaching end of life, the impact on patient, family regarding that lack of appetite, weight loss, and emotions. We'll look at interventions to support the patient and their family around intake of end of life, as well as review some of the stages of cachexia syndrome. We'll also look at artificial hydration, artificial nutrition in palliative care and end-of-life care. And hopefully we have some time to provide and go through a case study. So with signs and symptoms of approaching end of life, we're speaking of usually the last days and hours of someone's life, where you'll notice that the individuals are sleeping more, waking less or for lesser time frames, minimal appetite to no appetite, decreased or decreased interest of intake of fluids, decreased alertness or level of consciousness, increased weakness and fatigue is noted, as well as difficulty in swallowing food and fluids safely. They may exhibit dehydration signs, which is part of the natural dying process, which may include a decreased urinary output. It may be more concentrated, the output, skin tenting. There may be changes in their vital signs. They may experience a delirium or hallucinations. That's quite common as well. There may be airway secretions developed and changes in their breathing patterns, where they may have periods where apneic, where they stop breathing for a little bit, or they may have different breathing rhythms such as chain soaking. And changes in their skin coloring and temperature. You may see different colors towards their skin in regards to paleness may develop, or mottling, which is that bluish coloring that may develop to the lower end of the extremities due to the circulation declining. Their body is cool to touch, and sometimes some people develop an end-of-life temperature. Anytime if there's comments or a question, don't be shy to put it in the chat for Stephanie to indicate to me, okay? End-of-life journey. We do know that an end-of-life journey is unique to each and every one of us. We can all have the same illness, but because of our makeup and how we journey throughout our illnesses and that make us unique. We may display the symptoms that I disclosed to you in the previous slide, but in varying degrees to somebody else, depending as well as their disease progression. What we do know is with advancing age process and the illness process, it depletes the body of energy and strength. And that is a natural progression for physical changes to occur in preparation for death. And today's topic about food and fluids, that decreasing appetite or loss in interest in food and fluids is the natural physiological process that we experience. So what we do know is nutritional care is important to maintain our health, right? And to promote quality of life. But I have two questions I'd like you to, if you could, put into the chat the answers that come to you. What does food mean to you? And how does food or fluids impact your lives? Just to give you a thought of how much food and nutrition is in our lives. I'll give you a second just to think and perhaps invite you to put it into the chat.
So Marlene, so far we have home and comfort. Food means comfort and health.
Okay.
Return to school. There's a lot. Food is for nourishment. Food is family love. It is a major quality of life indicator. Celebration, comfort, nutrition, sustenance.
Excellent. They're on the right track of where I was going with this. Good, good, good. So we do realize how food impacts our life, not just the physiological aspect of it by providing nutrition for fuel, so to speak, but it also enhances us physiologically, spiritually, and socially, right? I think some of you have mentioned when you gather with your friends or have celebrations, what's in this celebration? It's food and drink, right? It's social events that bind us together. And spirituality or rituals in religions, they celebrate certain events, right? Christmas for those who take part in Christmas or Easter or any type of other type of celebrations through religion. 9 times out of 10, there's food and fluids associated with the gatherings, right? And psychologically, I don't know about you guys, but chocolate brings back nice memories to me as growing up. And I think that's part and parcel of it as well. So keep that in mind and how that impacts us and our ways of thinking or family members think when their loved ones are dying, right? We do know that we need food and fluids to sustain ourselves, right? Otherwise, death occurs. But some people may see it as a source of hope. As long as their loved one is eating, there's a source of hope that they're still living, right? That things aren't changing. And we also have to look at the cultural expressions. There's some cultures are more involved in cultural expression through nutritional care. That nurturing aspect, that caring aspect, right? I can honestly say for my husband's European, and that was the first thing that was always brought forward was food as an expression of caring at advance and for blending everybody together. But when you stop and you think about a terminally ill person who is closer to the end of life, they don't consume the foods or fluids in the same manner as they did before. There's that decreased appetite, that decreased desire to drink fluids, and it's not in the same manner. And we do know that that's part of the natural progression towards the journey in the end of their life. I would like some people, if you don't mind, to write down some of the reactions that you've witnessed of people when they realize that their loved ones are not eating as much, or they've stopped eating altogether, or stopped drinking. I'll give a second.
First one that came in, Marlene, was guilt. Will they starve to death? Fear, confusion, panic, concern, despair.
Right.
Re-
Excellent. You guys are on the same page as me, because what I've experienced in my nursing career is a lot of guilt from family members thinking they've done something wrong, that the individuals that are dying are not eating, or even reverse it, guilt the person that is dying to eat that can't, right? Or that blame. I did something wrong. In some cultures, they look at it as failure, right? So thank you for sharing that. It is very difficult, hard to accept. And that fear of death by starvation and dehydration is really, really quite evident in some situations. I have one quick story, and I promise I won't bombard you with stories, because once I start thinking of stories, they just kind of develop. One situation with a fear of death and death by starvation and dehydration come to mind when there was a client that was slowly progressing towards the end of her life. And you could see that there was changes in her appetite. And family could not accept that. It was really hard for them to accept. And we could not ever find out what the concern was until I call it my light bulb moment, because a few weeks later, the individual died. And the family member approached me and said, "I am so glad that my loved one didn't die skin and bones." And I thought, wow, that was the light bulb moment for me to realize the impact that that lack of food and appetite had, and the emotions that brought forth, that anger, that guilt, um, really was prevalent. And I always remind myself of that situation to delve further into having discussions. And that segues into how family members and other team members might need support and education um, in regards to the weight and intake of food and thirst along that end of life journey. If there's any comments, excuse me, or anything in the chat box, please just let me know if you have a story that you'd like to, tell us about, or additional comments.
Marlene, I did have a comment come in around tension between family and the team, hoping that you could talk more about what quote unquote realistic means, I guess, in terms of intake and
Regards to that, it's what I mean by realistic, that their loved ones are not going to be sitting down and eating 3 meals to sustain themselves. Realistic in the sense that as their body is shutting down, to try to get them to understand that that individual cannot consume that food, or has no desire for food or fluids, and to understand that where it can cause more harm than it can cause good, with the intentions that they're trying to develop. Does that help?
I think so. And I do see a
Another
hand.
hand.
Yeah. Melanie, I'll unmute you here. Did you have a question for Marlene, Melanie?
Going the wrong way.
Maybe she didn't mean to hit the button.
Oh, okay. I do that all the time, so don't feel bad if that's the case.
There's another question in the chat, Marlene. It just
Okay.
says, do people at end of life actually feel thirst, or is it more dry mouth?
You know what, we're going to discuss that a little bit further, but it generally is dry mouth, because what happens as they progress towards the end of their life, they become weaker, their jaw relaxes, their mouth remains open, and they have a tendency to do more mouth breathing. And sometimes some individuals hyperextend their neck. So the dryness that is created, and we'll further discuss that in artificial nutrition and hydration along the way. But good mouth care is helpful for that. Or if they're able, maybe just a few small ice chips, nothing too large, that could just melt in the buccal of their mouth, that would moisten their mouth. Or obviously, the last but not least, good mouth care to moisten their insides of their mouth. Was that helpful?
Thank you.
So when we're looking at supportive measures for family members dealing with patients or family members that are at end of life, we have to acknowledge that it's a very distressful time for the family, as well as the patient. But at 9 times out of 10, the patient is sleeping more, waking less, more I believe, going self inward. Sometimes they close themselves off to the families. But we have to explore what the concerns are, as with the story with the light bulb moment that I had. In hindsight, everything looks so much clearer, right? Exploring what their concerns were, why, the push for, forcing food, or really kind of, I won't say nagging for lack of a better terminology, but persistent, was so important, and not till after the death. did I really put all the pieces of the puzzle together? Because sometimes some people aren't forthcoming, and that's where it's really important to build those trusting relationships with the health team and the family members and the client, to have those open discussions. And for supportive measures, that's really key, that open communication, because what we can do is discuss goals of care. Have things been discussed prior to someone getting to this part of their journey, and asking what the client's wishes were when they did discuss it with the family, or knowing the family member best. What do you think your loved one would say at this point regarding those issues, right? As well as health teaching or educating families with the dying process. Alongside of, I think it's really important to know what the disease process may look like, because everybody's journey is different, as well as the education of the dying process, what a natural progression of death looks like. Reassurance to the family that comfort care will be provided. I've had family members call me up and ask, indicating that their family member is deemed palliative care approach. What does that mean? And having to explain that exactly that symptom management will be provided when someone no longer can eat or drink, and that they're not just left in the bed. I've had people approach me and say, they're not just going to leave them in the bed and not do anything with them, are they? So it's ongoing education about that reassurance, and that comfort care will be provided. And maintaining that, excuse me, pleasant surroundings in a calm environment. And that can be easily done with light music, lighting, pictures, things that are more familiar to the clients, reminiscing, right? So what can we provide the family to substitute that feeding portion and feeling the need to nurture in that manner? We can provide them other methods of helping them provide comfort to their loved ones. It can be simple as showing them how to maybe fluff and puff the pillow and reposition the patient. It all depends on what setting that the person chooses to have end of life at, whether it's in a nursing facility or at home. But those measures can be done by family members as well in every capacity there. We can help by helping them understand and how to provide activities of daily life. Simply even reading a book, or sitting at bedside watching a movie, sitting in silence, knowing that you're just supporting that person. And I know silence is really challenging for some, but their loved one will know they're in the room. I truly believe that. And one thing I want to backtrack on with the education of the dying process. When I was bedside nursing, I would review the signs and symptoms that I was noticing along the journey to the family, and I would explain it at the bedside, because hearing is one of the last senses that we believe diminishes. That even if the person is no longer conversing or awake, we don't know if they can hear what is being said. It's about their journey. They have the right to know what is happening to their body, and that this is the normal progression for the dying process. We also focus on dignity. For those on the call, they know that this is really important to me. That dignity and care, understanding what is important, what is dignity to these individuals. In importance of looking at the person holistically, not just the physicality part, but the psychosocial, the spiritual, cultural. It really plays an importance. There's so many more aspects than the food and fluids in that dying process that could help the individual along their journey. Providing quality of life, comfort measures, symptom relief measures, and looking at food as now a source of pleasure rather than a source of sustenance. we really have to accept what the patient can eat safely. And we also have to focus on what they would like to drink, when they want, the amount they desire and prefer, instead of forcing foods. We realize that we can encourage, but we have to really accept what it is that they're interested in eating or drinking or able to eat or drink. And we also have to look at the fact that forcing foods on people may create nausea and vomiting, bloating, or discomfort, depending on the individual. And not to mention, it puts that person at risk for choking and causing an aspiration. And if they're not able to swallow, it's time to look at options of other methods of providing that comfort. Just realizing good mouth care is really essential. Moistening, the lips and providing that mouth care is helpful. And then there's all those other ways of supporting somebody, right? It's just coming to terms with the journey has progressed to closer to the end of one's life. Anybody have any
Marlene,
questions? Yes.
There's a quick question in the chat, I guess, on that note. Kevin asks, have you experienced patients or clients at the end of life tell you that nothing tastes right, and that's why they don't want to eat, that everything tastes like garbage?
Right. There's a few reasons why people, I've also experienced people state that the smells are heightened, so it makes them nauseated. You'll have individuals say, oh, I would really just love a Dairy Queen ice cream. And so the family member thinks, oh my gosh, I can provide that. I can provide that. So they run and they get the Dairy Queen, and the ice cream gets to their mouth and they just touch the spoon and say that I can't do it. Right. So the taste may be off depending. Things may taste not like themselves, shall I say. There may be reasons that they're not hungry. Anxiety, depression can be included in that, as well as perhaps thinking of what the disease process is and how it impacts creating fullness. All those senses are heightened, right? Was that helpful, I hope?
Thank you.
Thank you. So we're going to look at some terms here, and it's just going to be an overview of cachexia, okay? So anorexia is that lack or loss of appetite for food. Cachexia is that involuntary weight loss or muscle wasting, which could include body fat loss, and it's a deterioration in the physical condition. Generally, what you'll see it in people in the later stages of advanced illness, such as cancers, congestive heart disease, lung diseases such as COPD. You may see them very frail and wasted. So those are just a couple of examples of some of the advanced illnesses that you may see cachexia. I would like to also indicate that cachexia is different from starvation. In starvation, weight loss is really caused by the reduced intake, and really the metabolism rate slows down to adjust for the reduced intake into the body, where cachexia is where the metabolism is sped up, right? It speeds up into a catabolic state, and where the breakdown of muscle and fats and lipids equate to the weight loss. And so even when a patient is taking in optimal nutrition or increased food and calories, the weight loss still occurs. And once cachexia stage is established, there really is no treatment to reverse that once it's started. And definition of sarcopenia is that loss of muscle tissue as a natural part of the aging process. So those are a few terms that I thought best review. And in this slide here, I'm showing you the stages of the cachexia syndrome. So there's the there's the cachexia and then the advanced refractory cachexia. You know how many times I've said that today? Way too many. So with the pre-cachexic stages, you'll notice these people are at risk for the primary, right? So what you'll see is that weight loss of less than 5% over about a 12-month period without really trying to lose weight. There may be changes in the metabolism causing inflammation. So that's what those are the changes are speeding the metabolism up. So how they can benefit in the beginning, in the early prolonged approach, is nutritional support and perhaps introducing more high-level proteins, counseling, exercises to maintain or build muscle, anti-inflammatory therapies, and appetite stimulants. So what we do know is that the cytokines that are produced really interact in with the immune system, and that alters the metabolism, resulting in that catabolic state, breaking down the proteins and the fats, and creates weight loss, as I indicated before. So once again, with reiterating that cachexic people, the metabolism is speeding up and weight loss occurs regardless if those calories or food is eaten. So with the cachexic stage, significant weight loss over 5% occurs. Appetite loss, increased fatigue, and you'll see that beginning of the muscle loss, wasting. And in this section, the interventions have limited benefits. They're not as successful as in the primary to maintain what they have. But going forth into the advanced refractory cachexia stage, that is where the weight loss is very advanced. There's no appetite, reduced functional status, increased weakness, increased fatigue. And these interventions that I mentioned at the beginning have no benefits at this point, where impact on their weight or their quality of life or life expectancy.
Marlene,
Yes,
we had a question about what are some examples of appetite stimulants you might use?
Some cannabinoids, corticosteroids, and bear with me with this pronunciation, megestrol acetate may be helpful for stimulating. And Nabilon, I'm sure people on the call may be familiar with as the cannabinoid that is usually used in this situation. Is that helpful?
Thanks, Marlene.
You're welcome. So we're just going to briefly review artificial nutrition and hydration specifically at end of life, but I will talk about what artificial nutrition looks like, who may benefit from it, but specifically this is for end of life, right? This discussion. So artificial nutrition can be provided through a tube feed, NG tube, PEG tube feedings, or parenteral, and that's looking at TPN, the total parenteral nutrition. But we have to first look at when is it used, if it's in the best interest of these individuals, if the cause of the weight loss is identifiable and reversible, that might be an option that may be used, but not at the end of life. This is probably earlier on. It may be used prior to a preoperative treatment of malnutrition in a surgical or resectable tumor, say in someone's cancer journey. But we do know that artificial nutrition does not improve quality of life or prolong it. So also we have to look at if the person requests it, why are they requesting? What is the concern? Where does this come from, that quest for it? And in times when people are not able to consume their fluids orally and they're not close to death, that might be an option. So with artificial hydration, that is providing hydration through hypodermoclysis. So it's a subcutaneous infusion of fluids, usually normal saline, and it's usually used to treat symptom management as an intervention for such things as delirium. Now, if it's a real end-of-life delirium, I don't believe that will have an impact. But if it is a reversible delirium, that might be something to investigate. Confusion, agitation comes from all different forms, so we have to investigate the cause. And sometimes it's used in nausea or vomiting. And in situations with opioid toxicity, you'll notice those myoclonus twitches that may occur. And I put goal to extend of life and hydration will help. And I had this one example to explain why I put that down. Many years ago, there was an individual that the alertness of this client was diminishing, and found through previous interventions of hydration that it picked up her, she was more awake, more alert, and family was coming from out of town to say their goodbyes. And she was wanting to have hydration to provide her that alertness so that she could converse with the family to say their goodbyes. And once the family left and went back home, this particular client decided to stop the hydration. So that's why I included that, those one-off situations that may be requested.
Marlene,
Yes, ma'am.
we've had a couple questions come in. I'm not sure if we might need more information or if my background's social work, so I'll just ask the question. When do we stop the artificial nutrition with a level D?
I think it has to be assessed on a regular basis. One, is it the person wanting it, or who originally initiated it? And if it's more harmful than helpful, and we have to teach family what was the reason for the nutrition? Was it to prolong life or use as a psychological support for family or for clients? We're really looking at to cause no harm to the individuals, right? So if we see that happening, that we have to reevaluate and have those discussions again with the family and the client. Hopefully that was helpful to some extent.
Yes, and we do have one more. We do a lot of boluses at end of life instead of HDL in our community. Is this not a good practice? Maybe not end of life, but at like 40 to 50 PPS.
No, I think that would be acceptable. What are you achieving? What is the goal? We have to look at what the goals are, the intent. If there's a rationale behind it, what are the goals of care? What are the wishes? At some point, that will stop, right? Because of the disease progression and the dying process. Once again, it's all about reviewing what are the goals of care with the family if the individual cannot speak for themselves. Short trials are often provided, but constant reassessments, making sure what the goal is intended for, and if it's been achieved for resolving a issue, then you can stop it, right? Or if it's no longer beneficial, to discontinue it. I have to say, once something is started, it's more challenging to remove it.
And Marlene, someone just made that exact comment pretty much. One of the things we talk about here is making certain to discuss with person family what might lead to stopping before we start these interventions. So yeah.
You guys are all on the same page as moi. That's good. Thank you for sharing that. So when we're looking at disadvantages of nutrition and hydration, both nutrition and the hydration require a medical intervention to be initiated, which is an order and consent, right? So with nutrition, it may cause inflammation, it may cause an infection, bruising or redness, or even pain at the site. With artificial nutrition, there is no pleasure in ingesting it because there is no taste, right? And may cause nausea and vomiting. It may cause bloating as well. So those are all the things we have to look at, continually assessing what are the benefits to the harms, and reviewing those goals of care. What's important to the client, maybe if they're no longer able to speak, but having those discussions with the family. If, tell me something about your family member. Would this be something they would want? What would they tell you if you haven't had those discussions, right? It's keeping that ongoing communication open. So when we're looking at artificial hydration, once again, it is a medical intervention. It requires an order and it requires consent. Once again, that may cause inflammation, infection, pain, bruising, redness at the site of the infusion. It also may increase the secretions, right? Depending on the individual and the amount of absorption. Respiratory congestion. People have heard the word death rattle. What those secretions are at the back of at the throat, the person is relaxed, so the pooling of the fluids. But once we introduce more fluids, more secretions are created. And depending on the individual's disease, it could create more respiratory congestion depending on what it is, right? As the body is shutting down, it's making more work trying to process the fluids and causing more discomfort. Segueing into urinary output, that may be increased, right? Twofolds to this. What additional things that may occur are skin breakdown, especially if they're incontinent, unable to use the toilets. And do they want a catheter if they're not able to void on their own and are incontinent? That's a dignity question, right? And we have to make sure that we're aware of what's important, of respecting what they feel is important or what they don't want. And with incontinence of urine and incontinence of feces, we're looking at skin breakdown. So that's potentially causing another issue, right? With fluid overload, you'll note edema and ascites. So you'll notice that the extremities start to swell, filling with fluid. The abdomen, where usually the subcutaneous or hypodermic lysis is really located or in situ there, may cause pressure on the abdomen, causing discomfort, causing nausea, even bloating, really pain, depending on what the situation is, right? So we have to look at all those situations and what is most beneficial. And once again, as I indicated in a previous slide with one of the questions, each person, we have to review their goals of care and what's important, especially at end of life, and remembering that dehydration at end of life is a natural progression, so that with people have a decrease in thirst. They may have a dry mouth, but there's other ways of providing symptom relief for a dry mouth, good mouth care. And just realizing that could be helpful. We have to make sure that, I know I'm repeating myself, but I really find this is important, that if hydration is used for trial purposes to see how the person tolerates it, or at the request of a loved one saying, I promise to do everything and I really want this to happen, to see if it can be positive. We have to monitor and reassess, maybe do it for a brief time, 24 hours. People can change at the end of life, on a daily basis, on an hourly basis, depending on how close to the end of their journey they become. And we have to discontinue interventions like this when they are no longer beneficial.
I know you have a few more slides, Marlene, but we did have a couple more questions come in,
Okay,
kind of
sure,
related to.
shoot.
So someone did ask if oxygen is a part of palliative care.
Once again, that's something that once you add, it's a little bit more challenging to remove. It's not really necessary, because once again, when someone is at that later part of their journey, they usually, as I had mentioned earlier in the beginning of the presentation, their mouth is open. You see the mouth breathing. They usually have hyperextended their neck, so airway is open, and it's part of the disease process. If you're doing nasal prongs, and sometimes even when people insist upon having a mask applied to their family member, they may even let you know that that's not something they want by tugging at it or removing it themselves. So those are some of the things we have to monitor for. Everybody's journey is different and everybody's family dynamics are different. So that's a good segue into ethics, I'd say. Is there any other questions, Steph, in regards to that, or?
Yes, Marlene.
Okay.
As an acute care hospital-based nurse, I have noticed that the comfort side of nutrition/meals is not easy due to mass production of foods and not having the ability to do snacks due to access. If family is not able to provide food from home, do you have any suggestions on how to help improve the meal experience?
In an acute hospital setting?
Mm-hmm.
Hmm.
Tricky.
That is SLP for perhaps textures. Maybe the diet could be just changed. When we're looking at someone at end of life and they want something to eat, you're not going to be looking at the 3 square meals to sustain their strength, right? We're looking at food as pleasure. So if ice cream is their wish, or milkshake is their wish, that, so be it. As far as how to go about obtaining that in an acute care setting, that would be something that they'd have to address the dietary. Maybe that could be arranged for, say, ice creams or something of that nature.
Thanks, Marlene. And one quick question about mouth care. What are your thoughts on utilizing club soda for mouth care?
I've never used it personally. I guess if they can tolerate it, I can't address it because I've never really used club soda.
Fair enough. And one last one here. It is important to make the distinction between palliative care and end-of-life care when discussing oxygen. Some people can require palliative care for years. At least that is my understanding. Is this correct?
I'd say so. Well, for this discussion, we're looking at actively dying patients closer to the end of life. When someone is early on in their illness trajectory, if that brings symptom relief, I would say yes, right? If there's no benefit, are you speaking of being beneficial physically or emotionally. Because I know when someone's at end of life, like, as I said to you before, it's really difficult to remove, say, even oxygen at end of life for family to see that. Generally, we would do that when they were removed from the room. And then when they enter back, it would just not be on, but it would be an agreement, right?
I think we're going to have you back for a part 2, Marlene. We're
Okay.
getting many questions now about what do you
Okay.
recommend for mouth care when artificial biotin or saliva is not available?
Even just water, just something to moisten, I think is helpful. On a tooth that just to wet. You know that Vaseline and such, if someone is on oxygen, is not a good idea to put on someone's lips with the hazard of the petroleum in it. Just for an FYI. So let's move on to the ethic portion of this, if you don't mind. So I know food and fluids is really a hot topic when it comes to crises with family. There's the conflict amongst themselves in regards to provide hydration or to certain care to be provided. So what we have to remember in these ethical crises moments is that balance between harm caused by withholding or providing that artificial hydration, right? Palliative care is really neither about shortening one's life or prolonging that dying period. It's to provide symptom management along the journey. And what we need to do, and this looks familiar from a previous slide, we have to acknowledge that family's distress. We have to explore their concerns, explore what they understand about the dying process, explore what they understand about the disease process, and having that ongoing communication, reviewing the goals of care and different situations that may change over time throughout the process. It's really important to know that educating them on the dying process, what it looks like, what may occur, and knowing that that's the natural progression towards one's life, end of life. Reassurance to the family that comfort care will be still provided when the food and the fluids are stopped. There's, as mentioned before, there's other methods of providing comfort care to a client, making sure that if they're in pain, if that's been addressed, or other symptoms that occur that are being addressed. Once again, that appropriateness of artificial hydration to be determined in terms of the harm versus benefits on a day-to-day basis. Really, it's not just you're going to initiate it and in a week from now we'll stop. It's a day-to-day assessment. As I said earlier, end of life can change over days, over hours, especially at the end of one's journey. So there's no proof that either giving or withholding fluids interferes with the length of remaining life or affects the comfort. And that statistics show that only 50% of patients have evidence of dehydration within 48 hours of their end of life. And to answer the question earlier about dry mouth, there's no evidence that thirst or dry mouth improves with artificial hydration. And going down to back at artificial nutrition and hydration at the end of life, while the body is winding down, making it work by adding hydration worsens, as I mentioned earlier, the respiratory secretions, increases that nausea, that vomiting, or the risk of it, just uncomfortableness, right? Increases that intracranial pressures if depending on the individual, right? And that uncomfortable urinary output, looking at dignity, looking at additional issues that may occur, skin breakdown, retention sometimes with the opioids that could occur, and then looking at Foley catheterization. And that might not be something that might be dignified to what an individual as well. So those are things that we have to think about. So in Canada, artificial nutrition and hydration is, as I mentioned earlier, is considered a medical treatment, and it is acceptable to decline or recommend withdrawal when justified and consistent with the previous wishes or in best interest of an individual. And also on this page, I've included a website that is the End of Life Law and Policy in Canada. That's designed for a source of information for the public, healthcare providers, media, and policymakers. So I just added that. So before we go into the case study, are there any additional comments or questions that people might have?
There was a lot of chatter about different things to use for mouth care.
Oh, good.
Yeah.
Please share.
We've had pineapple juice dipped in swabs can be helpful, helps hydrate and break down thrush. Moisture spray. Someone says they do use club soda often if the resident likes it. The bubbles can be refreshing. Liquid coconut oil for more moisture. And someone said whatever they like, whiskey and cola, if that's
something to moisten, right? It all depends on the individual, right? It's trial and error. What works for one may not work for another. And you know, at some point, maybe even just putting a swab with even just water, they may not want that as well, right? So we just have to be mindful of the situation that it occurs in. Anything else there, Steph?
Someone just added that they hand out little travel spritzer bottles for families to use if folks don't like the swabs.
Well, thank you for sharing. So, how's time coming, Steph?
I think we might need to save our case study, Marlene.
Oh,
And maybe when we send out the slides, people can reflect, or maybe do you want to read it quickly? And
I can read it and then give them, everybody online, food for thought on how they would answer it. How's that?
sounds good.
So Mrs. Jane Smith is an 86-year-old woman with advanced dementia. Jane has been diagnosed with dementia over 6 years ago. Following her diagnosis, she had moved in with her daughter, Sarah. And Jane has been slowly declining over the first 5 years of her diagnosis, having difficulty swallowing at times, which caused her to be admitted to the hospital on 2 occasions with a diagnosis of aspiration pneumonia. Jane has since lost 20 pounds and appears to be more frail. Since her last discharge from hospital approximately a year ago, Jane was admitted to long-term care and has declined over the last 6 months, becoming bedridden and total care. Sarah, the POA, is distraught over the decline she sees and has stated she wants her mother to be comfortable, but does not want her to starve to death. My question is, how would you manage this situation? And what were the things that you would do, or what are the items, the situations that you would assess? What questions would you ask? And what types of communication would be needed? So I'll let you guys think about that. And my references. And Steph, do you want to comment on future Palliative Care ECHO Series?
Yeah, thank you so much for the presentation today, Marlene. Definitely always a hot topic. And as you framed it, it definitely really is more about the meaning behind food and fluids. So yeah, we might need to have you back for another session. But I did just put in our chat for everyone our session evaluation link. We really appreciate it if you could take a minute just to complete that for us. We do have another echo session. I should put my camera on too, coming up in just a few weeks now, actually, with Dr. Erin Gallagher, and she'll be speaking about incorporating a palliative approach into your primary care practice. So thank you all so much for attending today and for your participation. And we hope you'll join us again in a few weeks. And again, we will be sending out the recording as well as Marlene's slides to everybody as well. So have a great day. Take care all. Lots of nice thank yous for you there, Marlene.
Yeah, I noticed it was stated a couple times that people have had some light bulb moments, and I always love those, right? When you make people think of something that they hadn't thought of before. So well done.
I'm going to stop sharing, okay?
Yeah.
Okay. So
See you in a minute, Marlene.
Hey.
We'll see you in a minute.